Welcome to the 3-Minute Read podcast. I'm John Dalton, editor of the twice-monthly newsletter of the Healing American Healthcare Coalition. Joining me once again is Ed Eichhorn, the coalition's co-founder and co-author of Healing American Healthcare, a plan to provide quality care to all while saving $1 trillion a year.
Good morning, John. It's good to be with you again today.
Well, between us, Ed and I have nearly a century of healthcare experience, and we're still trying to figure it out. You can find our background and contact information at the end of the podcast. Ed and I launched the 3-Minute Read a year ago to summarize some of the critical issues affecting busy clinicians and physicians as they struggle through this pandemic. To date, we've summarized 132 articles from 50 different sources on 8 topics, including physician practices, insurance coverage, drug costs, and of course, the pandemic. President Biden took office 57 days ago and wasted no time in declaring war on the pandemic. He signed 10 executive orders that first day to jumpstart his national COVID-19 strategy. Today, more than 73 million Americans have received at least one dose of vaccine. So let's dive into the issue and see how this war on the pandemic is going. As you can see in our March 16th edition, we have 5 articles, 4 of which deal with various clinical issues, and then the final one, the healthcare industry seeks common ground with Biden, is right in Ed Eichhorn's wheelhouse, and he'll be joining us to discuss that article. The first article is about UPMC and their 3-front fight against COVID. It was in Modern Healthcare's February 28th issue, titled Fighting COVID on 3 Fronts, the University of Pittsburgh Medical Center Health System. Now, in Western Pennsylvania, the University of Pittsburgh Medical Center Health System is the 800-pound gorilla anywhere west of Harrisburg. They have 35 hospitals and 90,000 employees. And what that gives them is the critical mass to be able to invest in research efforts and finding ways to deal better with some of the issues that are emerging. There's pluses and minuses. They're the 800-pound gorilla, but they are also making some progress in terms of looking at how best to deal with issues like the pandemic. So the first one is general masking. They took a closer look at mask strategy, including fit testing for N95 masks and availability. And they found that there were a number of areas in which they could improve their use of masks. So their degree of preparedness needed to be a notch higher on an ongoing basis. On contact tracing, UPMC created a contact tracing app that has allowed the health system to stay ahead of the game on the coronavirus. Nearly all of their employee exposures did not come from contact within the health system, but really from community events outside of work. We have a quote there from their Chief Quality Officer, Terry Manier, who said, "Our contact tracing app really allowed us to contain things quickly." The third area where UPMC was ahead of the curve is on mass vaccination. They had already researched ways to accelerate mass vaccinations and tested their approaches with the influenza vaccines, getting vaccinated in the fall for the seasonal flu. When the pandemic began, they already had a structure in place to mass vaccinate their employees as well as workers in nearby health systems. Again, a quote from Terry Manier, she talks again about how this has helped facilitate getting people vaccinated. By mid-February, 80% of their healthcare employees had completed their first dose of the vaccine. And UPMC is now making that capability available to other non-UPMC hospitals and health systems. The second article is a subject that we first looked at back last August with 2 articles in our August issue that dealt with long-haul COVID symptoms. And actually now there's a definition for what is a long hauler. It's a person who suffers from symptoms of COVID-19 for longer than 2 weeks and generally for several months. In that August issue, we had talked about a neuroscientist, Athena Arkrami, age 38, who was not able to return to her neuroscience lab in London. This was the end of July. She had contracted the COVID-19 in March. She was suffering from brain fog, occasional muscular difficulties, and so 4 months later had not been able to return to work. In that issue, we also talked about the long-term healthcare costs that would be associated with COVID-19. And in that article, we also talked about billions of dollars in costs and long-term care costs. We also commented about Mount Sinai leading a multi-center trial to monitor patients who had long COVID. And two quotes from that article. We quoted Dr. Gregory Poland, who's a COVID-19 expert at Mayo Clinic. He warned that some of the possible long-term effects can even affect patients who are asymptomatic and have mild cases. Quote, "I think it's an argument for why we take this disease so seriously. We're going to need to study those as vigorously as we did the acute symptoms." Dr. Anthony Fauci also pitched in talking about long COVID, that, quote, "brain fog, fatigue, and difficulty in concentrating. This is something we really need to look seriously at." And now we're seeing much more on the subject. For example, New York Times editorial board member Mara Gay had a case of COVID that resulted in long COVID symptoms. After getting her first vaccine dose, 2 weeks later, she felt much better. And we've seen her interviewed on occasion on cable TV news. A UK survey found that 16% of patients said their long COVID symptoms had improved by 2 weeks after the first dose. So that's encouraging news. Yale University's Akiko Iwasaki, PhD, again, a person we've quoted before in previous articles, he has suggested studying three potential mechanisms that drive long COVID. Is it a persistent viral reservoir? Is it viral fragments or remnants that drive inflammation? Or is it an autoimmune response induced by the infection? Stanley Weiss, an infectious disease specialist here in New Jersey at Rutgers New Jersey Medical School, agrees with Iwasaki. Quote, "The way you progress in science and medicine is that you take observations from expert observers and pursue them with scientific rigor." And that's very important that we do that on the COVID long haulers front, because remembering back to insurance before the Affordable Care Act, insurance underwriters want to cherry pick their risk pool. Long COVID now is a pre-existing condition. Next article in the issue dealt with the Novavax vaccine, as from Reuters on March 11th. Novavax vaccine is 96% effective against original coronavirus, 86% versus the British variant in a UK trial. That UK trial enrolled more than 15,000 people aged 18 to 84. It assessed the vaccine's efficacy during a period with high transmission of the UK virus. That virus variant B.1.1.7 now is circulating widely, including here in the US. What did they find? Novavax's vaccine was 96% effective against the original variant, the one that we've seen most prevalent over the course of the last year. It was 86% effective in protecting against the B.1.1.7 variant. However, in South Africa, it was only 55% effective. Still good, but against the South African variant, it did fully prevent severe illness. Now, Novavax expects their 30,000 person clinical trial in the US and Mexico to have complete data by early April. The vaccine could be cleared for use in the US as soon as May if US regulators decide the UK data is enough to make a decision. However, that's probably a long shot. For the FDA to accept another nation's data would be, to use an overworked word, unprecedented. So that's less likely to happen, but once the US trials are completed, it's likely that Novavax ultimately would get an emergency use authorization within the US. Having the Novavax vaccine available will give us yet another weapon in the vaccine versus virus race to recovery. We already have 3 with the Moderna, Pfizer, and single-dose J&J vaccine. Ultimately, when the Novavax vaccine is approved for use in the US, it's another single-dose vaccine that will be helpful in this race to recovery. Mm-hmm. About the same time as the 3-minute read hit everybody's inboxes on Tuesday, the New York Times Morning Report had an interesting chart that really shows how this vaccine versus virus race is progressing. So let's take a minute to look at this chart. It shows how vaccines are slowing the spread of the coronavirus. the change in new daily COVID-19 cases per million residents over the last month from February 14th to March 14th. The countries listed are listed in sequence of the doses given per 100 people. And as you know, Israel has been the most aggressive in terms of its vaccine rollout. And at March 14th, had administered 106 doses per 100 people. And you can see how dramatically the number of cases dropped because of this aggressive vaccine administration. United Arab Emirates, 68 per 100. Britain, which unlike the rest of the EU, was very aggressive in its rollout because of the concerns about the B117 variant, that has had a major positive effect in terms of the number of new daily cases. Chile, for some reason, has gone in the opposite direction, although their vaccine doses were up to 35 per 100 people. The US at 32 per 100. I checked this morning, that's now about 34 per 100. You can see that the race to recovery is on. The number of the daily cases still too high, but coming down steadily, about half what they were at the peak in the winter surge. So very important that we get those shots into arms. As of yesterday, something like 113 million doses had been administered in the US. On the day that President Biden was inaugurated, that number was 16.5 million. So that's quite a change over the last 57 days. The next article deals with an issue that we first talked about back in September. It's from The Hill, and it was written by Joseph Choi on March 4th. Most virus deaths recorded in nations with high obesity levels, and it produces an analysis. And the linkage between obesity and COVID-19 is something we first talked about back in September issue. There was an article from the Associated Press, doctors studying why obesity may be tied to serious COVID-19. And it mentioned some of the studies that were then showing that high body mass indexes were a significant complicating condition for those who contracted COVID-19. So let's look at the article. The World Obesity Foundation, which is an organization I didn't even realize existed until I saw this article, they are affiliated with the World Health Organization, and they're located in London. They put out an annual report that looks at virtually every country in the world, and they found a connection between increased COVID-19 deaths and high obesity rates. And this is a quote from the report. Comparing countries around the world, we find a close association between deaths from COVID-19 and the prevalence of overweight in the adult population. The connection between increased risk of severe COVID-19 cases or death and higher body weight was observed across multiple countries, but much less so in many of the poorer countries in the world. And I know there's been a lot of concern about vaccine distribution to many of the poorer countries. For a number of reasons, they are in much better shape with respect to COVID-19 than is much of the OECD. And we'll see some of those connections in a minute. A recent US study reported that obese people were twice as likely to be hospitalized with COVID-19 and 6 times more likely to die after developing the disease. So it is a major concern. A Brookings Institution study agrees with the World Obesity Federation's findings. Quote, a large part of the positive correlation between income and deaths per million is due to the age distribution and obesity. So let's take a look at the US data from the World Obesity Federation's annual report. And this was extracted from their report. The first table is one that they present for every country in the world as of January 1. And that 105.68 COVID deaths per 100,000 population is consistent with the numbers that we compiled as of December 31st. In the US, as of 2016, 67.9%, more than 2 out of 3 American adults is overweight. And obesity, that's a body mass index greater than 30, 36.2% of us are obese. The US population over age 65, 16.6. And that's one of the differences between major OECD developed countries and the developing world. We see a lot less overweight, a lot less obesity, and a lot lower percentage of population over 65 years in many of those poorer countries. You're doing better on COVID-19 than are we. They also present a table for each country that shows the 2010 target and 2025 predicted prevalence and number of cases of obesity and overweight. So for the US in 2010, men were about 1 out of 3 males and 1 out of 3 females was overweight. In 2025, those numbers are projected to go up to 44.2, 44.4%. And more troubling trend, obesity in children, 20.1% in 2010 and close to 1 in 4 by 2025. Now, looking at the CDC data, what surprised me, in 1995, the obesity rate in America was 15.6%. So 1 out of 6, 1 out of 7 adults was obese. That moved up to 19.8% in 2000, 1 out of 5 adults, and 23.7% in 05, almost 1 out of 4 adults. So clearly, the fast food nation is eating itself to death. And this next article is right in your wheelhouse. Any comments before you tackle this one?
I think the articles that you covered, John, certainly are important with respect to COVID and where we stand today, and how organizations have worked to, try to keep their employees safe while dealing with patients. This article appeared in Modern Healthcare on March 8th by Lola Butcher. It's entitled, "Healthcare Industry Gearing Up to Find Common Ground with Biden." Generally, the healthcare industry agrees with the Biden administration. The current top priority has to be the COVID-19 pandemic, followed by increasing insurance coverage. In support of that and their common ground, lobbies representing providers, payers, and employers formed the Affordable Coverage Coalition, whose goal is to achieve universal health coverage through a number of steps. Let me digress a little bit here and tell you who is in this coalition. It includes America's Health Insurance Plans, the American Academy of Family Physicians, the American Benefits Council, the American Hospital Association, the American Medical Association, the Blue Cross Blue Shield Association, the Federation of American Hospitals, and the U.S. Chamber of Commerce. And when they formed their group in February, they put out a document, and I'd like to share the first paragraph with you to give you a sense of the magnitude of this new lobbying organization. They represent the nation's doctors, hospitals, employers, and health insurance providers. Collectively, the organization includes hundreds of thousands of individual physicians, thousands of hospitals, and hundreds of employers and health insurance providers that serve hundreds of millions of American patients, consumers, and employers every day across the United States. That makes them a very, very powerful group. And, they are interested, working with the president's administration, to enhance ACA premium subsidies and provide incentives for more states to expand Medicaid. This includes things like they support tax credits and cost-sharing reductions, insurance affordability, automatic and facilitated enrollment, federal funding for outreach and enrollment, incentives to close the low-income coverage gap, and preventing increases in the number of uninsured. And those things all align with their overall mission or the shared missions of this number of lobbies that represent such a large percentage of healthcare providers and insurance providers and employers. Now, while they agree on many things, members of this coalition do not agree with creating a public option that would allow people to buy into Medicare, or reducing Medicare eligibility age to 60. In fact, they cite a survey from 2019 that suggests that a government-run Medicare-like option would lead to nearly $800 million in provider payment cuts over 10 years while utilization was growing. Now, if you think about it for a moment, they are very supportive, as all lobbyists are, of things that are good for the members of the lobby. They want more patients, They want those patients to be paid for. And certainly physicians that see the patients would like to be paid. Hospitals would have less unpaid care that they don't want. Employers would have more covered employees. And those things are all good for healthcare, but they're especially good for that lobby. A Medicare-like option or a public option is good for Americans, but it's not as good for this lobbying group. Now, if you're going to have more people on Medicare, you have to look at the trust fund. And the article reports that the Medicare trust fund is projected to have insufficient funds to cover its obligations within 3 years at the beginning of 2024. And in response to that, Commonwealth Fund's CEO, Dr. Blumenthal, said that if Congress wants to give more people the coverage that Medicare offers, there are ways to fund it. It's just a matter of finding the political will to do so. Now, during the pandemic, the article also reports on the expansion of telehealth to fill the gap. And it's made healthcare more accessible and more affordable, especially in rural communities. And there is a general bipartisan support on this issue, as well as on drug pricing. The American Hospital Association's Senior Vice President for Policy said, "We're going to need help from Congress to remove some of the key barriers in order to make telehealth continue being used as it has during this public health emergency." Now, of course, the lobbying organization for the pharmaceutical industry is not on board with all of these things. Their representative said that government price setting is a bright line that the industry is unwilling to cross. They believe that their success in rapid vaccine development provides the clout needed to oppose price controls. But we also should understand that for many of them who have developed new drugs and vaccines, they receive payment from the federal government to do that. John reported on Novavax in an earlier article. Novavax is steaming ahead to make vaccines in preparation for getting approval for their use. But they were also paid $1.6 billion from the United States federal government to do so. So we need to keep these issues balanced between what the government is paid for and what the lobbyists are representing for the industries that they represent. It's also important to understand that there have been a lot of workforce issues associated with the pandemic. It has severely strained America's healthcare workforce. And in fact, to help with part of that, a bill in December authorized Medicare to fund 1,000 additional physician residency slots. And this is very important because the Association of American Medical Colleges predicts a shortage of up to about 140,000 physicians by 2033. And they see this as an opportunity to begin to address this projected shortage, because to project a shortage means people have to go to medical school, graduate from medical school, and do their internships and go into practice. That's a very long lead time. So having 1,000 additional residency seats makes good sense in a time like this. The bill that was recently passed, the American Rescue Plan, actually provides for funding for 100,000 additional public health workers, and they are going to be sorely needed as we address growths in care over the next several years. We also wanted to share with you that there was a recent study by Populous, which is a Massachusetts think tank, and the study that we are referencing here was conducted very recently. It was conducted from January 21st to January 28th. And it found that across race, gender, income, education, and generation, after the 2020 presidential vote, there is a great agreement in America's long-term national priorities, regardless of whether a person is a Republican or Democrat or which presidential candidate they voted for. The leading one among these was high-quality health care as a necessity, not a privilege. And there was also an overwhelming commitment to individual rights and upholding equal treatment for all. but that doesn't necessarily mean there would be equal outcomes. Very interesting article. In fact, there's a quote at the beginning of that I thought I would share that relates to all the lobbying we talked about in this article. The quote is from Abraham Lincoln in 1858, and he said, "Public sentiment is everything. With public sentiment, nothing can fail. Without it, nothing can succeed." And I think all of these efforts for lobbying organizations to make their points in support of the Biden initiative, and also where they disagree, are really important for the public to embrace and understand as these efforts go forward.
Thank you, Ed. So where is the coalition for the public? That's the key question. I mean, that's an all-American group that you talked about for the Affordable Care Coalition. And their aims are laudable, albeit a bit self-serving and somewhat one-dimensional. Some of their aims make a lot of sense. For example, they are talking about things that we can all endorse and support, such as automated and facilitated enrollment to get new individuals enrolled in Medicaid and premium-free marketplace plans, and to facilitate enrollment for any remaining uninsured. Biden has opened up healthcare.gov through March 31st. We're starting to fund navigators again. That's all good stuff. They're talking about preventing increases in the uninsured to help prevent Americans who have lost or are at risk of losing employer-provided health coverage from becoming uninsured, funding COBRA benefits and that kind of stuff. That's all good for that coalition, but who's really looking out for the patients and making sure that the public needs are met? Anyhow, enough of the editorializing, but after spending 35 years on the boards of not-for-profit hospitals that have to run emergency rooms 24/7 and accept whatever patients come through the door, I get a little bit upset with some of the lobbyists and their rather entrenched positions. We really need to simplify and streamline healthcare, get rid of some of that administrative and clinical waste, and we'll be talking more about that in future issues. Speaking of future issues, if you haven't already done so, please take our healthcare survey at www.healingamericanhealthcare.org. We're interested in your insights and views. In future podcasts, we'll be sharing feedback with our listeners on issues that include universal health care versus Medicare for all. And Ed will be looking at some of the legislative proposals that are currently moving through the Congress. We're talking about the Eichhorn Hutchinson All Care Plan that can save up to $1 trillion a year for American healthcare. We'll be talking about prescription drug pricing and much, much more. This morning, we saw the announcement that Amazon is moving out with its telehealth proposal and will be making their telehealth platform available to all American businesses. Again, telehealth is here to stay. So we'll be discussing some of that in our future podcasts. So thanks again for listening. If there are issues of particular interest that you would like to see covered, please feel free to contact us. And here's our contact information. If you're interested in joining our mailing list, text HEALED HEALTHCARE to 22828 to get on our mailing list. Until next time, wash your hands, watch your distance, and wear a mask. Thanks for joining us.